seizure because it can occur in any of the conditions that affect the central nervous system because it will cause a malfunction or malformation of the brain electrical system. So there is a dysfunction that is not, the electrical system of the brain is not functioning as it should. Okay, it's functioning erratically, so that's why it can affect any condition that affects the central nervous system. However, it is classified or defined as the origin of the source of the impulse or the area of the brain that is affected. But overall, we know that seizure activities can cause changes in the level of consciousness of the person. It can alter the movement, result in involuntary movement. The person really did not mean to move the way they are moving, like having the checking movement, or so they really did not intend to do that, but it was an involuntary response due to that alteration in the electrical activity in the brain. Another thing that the seizure would do would be to alter changes in the person's behavior, perception, and or sensation. You will notice that the person may be able to lose consciousness after the seizure activity. They can become incontinent. Some of them may know when the seizure is coming. Some may not know. Some may have loss of consciousness after the seizure, and some will sleep through afterwards. Anything that can lead to alteration in the brain cells have a potential of causing a seizure as a complication. Meaning things like injury to the head can have a consequence of a seizure activity. High fever in children can put undue pressure to the cerebral tissue and can lead to seizure activity. Seizures can be classified, described also as they are generalized or unspecific, or it could be a partial. On the other hand, some of the seizures have no identifiable cause. Like we said, that we are linked seizures to injury to the brain or to any assault to the brain or to fever or anything. But some of the seizures have no cause at all. We cannot associate it with anything. And just the person develops that seizure. These are the ones that we refer to as idiopathic seizure disorder. Seizures can be described or can be defined as epilepsy. So the person just have one-time seizure activity, we do not classify that as epilepsy until they have two or more. And and then it would be classified as epilepsy. So a single one-time seizure, the person presents to the ER and say, okay, my child was in the class today and they had this seizure, or at home, child developed had this seizure lasting for this number of time, 5 minutes, 2 minutes, 1 minute, and they come to the ER. They will put it as seizure and not as epilepsy. Once it's 2 or more, then it will be classified as epileptic seizure. And there are several types of seizures or things that can put the child at risk. Family history will be one of those, in addition to our injuries that we talked about. Complications in pregnancy. When we looked at things that can lead to increase in intracranial pressure, we talked about that, and it's a consequence of that. So all those changes that we noticed or we identified previously can put the patient at risk for developing seizure activity and or epilepsy. Any recent illnesses, fever, trauma, or toxin exposure to toxin, viral infection or actual bacterial infection can lead to seizure activity overall. So, common types of seizures, we have the infantile, absent, tonic-clonic, myoclonic, atonic, simple, partial, complex, partial, and static epileptic. I'll just kind of put a description of some of them that we have. The infantile seizures or spasms usually will occur for the first 6 to 8 months of life. And these are usually associated with some cognitive dysfunction in the child. Okay, and it's possibly due to dysfunction in neurotransmitters in the brain, especially when you have lack of oxygen in the brain, anoxic brain injury that occurs in utero, or sometimes extrauterine anoxic injury when the child has apnea, prolonged apnea that deprives oxygen to the brain. That can also lead to injury. So what happens here is that the head and the neck are flexed forward, while the child will just have that twitch. And during those movements, the child may or may not lose consciousness during infantile spasm. What you will notice, however, is that the child's heart rate will be high. You have tachycardia. Child will become very jittery. And you notice like there's a deviation in their eye. The eye will move either deviate to the right or to the left. And if you did check the blood pressure, you'll notice that the blood pressure will be slightly elevated for this children. Absence seizure, I will just describe them all and then we'll do the treatment to follow all of them. Absence seizure is the one that's commonly called petit mal. And in this, there is brief loss of consciousness with or without change in the muscle tone. and it affects children ages 4 to 12. Usually there is no warning sign for this, there is no aura, so the person does not know when the seizure is about to take place. Usually they are not incontinent as well, because some of those patients, after they have their seizures, they become incontinent. The child may just be appear like staring into space, or not paying attention to what is going on within their immediate environment. And this is the child that they, in grade school, the classroom teacher will say that, the child is sometimes on their own and do not pay attention to what is going on, when in fact the child is having problems. And you can only know that the child is having problems from the result of the EEG. So looking at the child, physically you say, oh, nothing is wrong with this child. The child is just playing, not wanting to be part of what is going on. Sometimes it will just be a twitching on one side of the body. It could be the hand or the arm or the eye, or to believe smacking. And they just like, just as if nothing is happening, but they don't know that, they are doing that. And these are the children that, kind of we see in school. Myoclonic seizures, on the other hand, that's the one you have the contraction of the muscle or group of muscles. And usually after this seizure activity, the patient may fall asleep. Usually they do not lose consciousness. They are very fully awake and alert and awake, but they can fall asleep once everything is over. Again, you know the startling reflexes in the newborn that, all of a sudden they just did that. So that's kind of something. You may even equate this as somebody that have a fetal alcohol syndrome. They're just irritable and just twitching so much. So that's what this one would look like. Yes.
So pretty much, they can tell you everything that happened to them.
Huh?
They can tell you everything that happened to them.
They can, if the child is old enough, yes. Now the drop attacks or the atonic seizures, these are the ones that suddenly, they lose muscle tone. Again, they may or may not lose their consciousness. And these are the ones that are at risk for injury, because the person can be standing or sitting in a chair, and all of a sudden that happens, they fall off the chair or they just fall on the floor. Some of them will be like, they just do something like this, and that's their very big seizure activities for them. I had a patient like that years ago, and we had this patient at home. Our nurse would take the child to school, but this child was having significant amounts of seizures and we weren't capturing all of them. All we know that the patient will just do this. You know, sometimes she'll just sit on her chair and going like this. That's all we know about. And we weren't recording those as seizure activities until she went to have her EEG done, video EEG. And it was captured on the video EEG that all those times she was just doing this, she was actually having severe seizure activities. We were like, okay. And we thought it was just behavior, but not that she was really in trouble with the autism. Febrile seizures, on the other hand, will be a seizure activity that you will see in children up to the age of 3 years. Once there is an increase in temperature, of anywhere above 102, that child runs the risk of having a seizure activity. So the strategy would be to do whatever you can to bring that temperature down to under 101. That's your strategy. To bring that seizure activity down, the temperature down.
She had to go to the bathroom. What happened?
Yo, let's map out our schedule after this. Let's plan our schedule after this.
After what? After class?
Yeah.
Okay.
Number 52.
For which one?
American. It's 6 holes. You take. No. I think. No, I'm kidding. Yeah.
Did you take a core this? What day is that?
Do you talk to Adrian?
Monday.
Because she ended up in Bergen.
Yeah, I'm gonna talk to her.
Fuck just happened to Carriage? I mean Carriage.
Not a bad schedule. Just that random Friday sucks.
That sucks. You can't even bypass it.
Oh, you got 5 days a week?
We have community on, no, research on Friday.
It's the only.
Usually if you get Tuesdays or Thursdays for clinical, you only have 3 days here. So either way, you have 2 days off.
Did you put in your clinical day?
Yeah.
You could have class.
Tuesday, that's what Karen did.
Sorry about that. So for this febrile seizures, our strategy would be to reduce that fever by all means. Okay. Now, other types of seizures, epilepsy that we need to know would be the status epilepticus. And this is when you have a seizure activity that lasts more than 13 minutes. This is intermittent or series of seizure activities, from the initial onset, you notice it. So, the child keeps on like intermittently will continue to see over a period of half an hour. This is not good anymore because there is this constant action in the brain that is not allowing the brain cells to rest and get enough nutrients and oxygen into the brain. So you do not want that to last that long. Most of the time, it happens, it is considered an emergency. The child needs to go to the emergency room to be treated, and usually they are admit them into the intensive care unit because they need to control that seizure activity. Okay, so the management for this particular one will be to maintain the airway, give IV fluid, and give medications to stop that. So overall, once you are treating a seizure activity, I'm just going to do the whole treatment and then we'll focus on each one. So we would like to note the history of the seizure, regardless of what it is that causes that abnormal brain activity in the brain. Regardless of the characteristics, we would like to note what it is that caused it or prompted that process to happen in the first place. And then most often, the neurologist would like to control the seizures. They can use, these days, it's more common for them to use a combination medication to control it. They will have to titrate the medication, put the medication in place in such a way that they will be able to achieve seizure control with the least minimum of side effects from that medication, because all seizure medications have their side effects. So they would like to up the medication to use a combination or a triple medication to control the seizure with the least amount of side effects. That will be their goal. Okay? So some of the medications they'll give something like Dilantin, which is our old first line treatment. They can use things like Tetraprol, barbaric acid, Depakote, all these are the newer ones, Trileptis, they'll use all those, but on the bottom line, all these have side effects, and they will also have to be titrated just to control the seizure without the side effects. Other things they can do would be to other things they would do would be to give something like the ketogenic diet. The ketogenic diet can be used in combination, in conjunction with the medication, but most often I've seen them using it when they've tried several medication combinations and they're not getting the optimum seizure control that they want, so they include the diet. And what the diet is doing is that the diet is supposed to be a diet that is very high in ketones, fatty diet with little or no carbohydrates. Ideally, what you want to do is for the person to have a high level of ketones in the body, in the bloodstream. And with that, it is believed that those ketone, high ketones would help to alter the electrical impulse in the brain, and they bring about seizure control. But to maintain that diet is very difficult for a child and for the parents, because for that diet to be for the diet to be appropriate, to be said to be good, that they are maintaining that diet, you need to see that level of ketones in the body. And if you are not maintaining a high level of ketones, then you are not compliant. That's the way it will sound, as if you are not compliant, because the body is supposed to be utilizing those fat as a source of energy to bring about the ketones. And with that, high level of ketone comes with its complications to the body. So this person needs to be monitored very closely as they are taking that ketogenic diet. You raise your hand? No? Alright. So other things that can be done would be to use the vagus nerve stimulation, and this is just like an implanted device that we put under the skin. It looks like an AED or like a pacemaker, if you will, but it will send its own, it will have its buttons that send electrical impulses to the brain to alter each time there is an abnormal electrical impulse. Other things they can do might be to do surgery, and that surgery would be to do a partial lobe removal of the brain. Some patients, at least I know of one that had, actually two of them that had partial lobe removed. In spite of all that, they still having their seizures. Their seizures they couldn't control their seizure pattern. So they went to University of Maryland, had they come back, the seizure is still there. The other one added their diet and it was okay, but there was a big problem to control that diet, especially the class with school-age children, classroom environment, school parties, friends, sleepover, with all that has a lot of, challenge for the child and for the family to maintain that diet. Again, the big thing with your control will also be your seizure precaution, because you would like to maintain wellness and you would like to prevent injury. And with your seizure precautions, you know that before the child even gets to the unit, to the hospital you are admitting the child, you need to have like a padded cycle, and that's something you are instructing them at home to do. You teach the parents about seizure, what it is and what can trigger it, and when to call 911. And if you are in charge of a child who is having a seizure activity, you know that you cannot put anything in that child's mouth. Nothing in the child's mouth, ever. You will have to position the child on the side, protect that child from injury, remove everything that can potentially cause injury. So if the child is standing and you saw the child, or you could safely let the child down. You will have to note the child's movements and positions. You will have to, part of your documentation, you would like to note what the child was doing before that event or the seizure occurred. Was the child crying? Was the child exposed to a bright light like we had in the the light, what is it called? That the child light specialist will use when you're going to distract a child. Well, did you expose that child to something like that, or did you expose the child to suddenly a bright light? if the child have any fever or anything like that, you will have to document the time that the seizure started and how long it lasted. After the seizure, you would like to note the level of consciousness for that child. Was the child awake? Was the child sleepy? Was the child unconscious post event? Any type of cyanosis? Or not? Any type of incontinence? Stool or urine or both? And then all this you need to, document in your seizure log what the patient did. In terms of the medication, you have to teach the parents about the medication. The seizure medications you cannot stop abruptly. You need to tell them they must continue their medications. Otherwise, because you would like to maintain a therapeutic level of the seizure meds. And when the physician, when the neurologist, when they want to increase the seizure medication, they can. They look at the therapeutic level, they look at what the child is doing, and they'll be able to increase that level until it controls seizures without unnecessarily severe adverse reaction or toxicity. And when they are going to discontinue the seizure medication as well, they have to taper the dose down. It's not something they'll wake up one morning and say, boom, we'll stop with your discontinue your seizure medication. No, they cannot do that. And usually when a child is seizure free for 2 years, and when they look at the EEG, there is no activity to suggest that the person has a seizure activity or has seizure activity, they can plan to wean the person off the seizure medication. While monitoring, as they are weaning off the medication, they are monitoring the EEG to see if there is any reoccurrence of the seizures with the lowering down of the medication. And as they do that periodically, and there is no seizure activities, both physically that was reported, and or there is any evidence of seizure in the EEG, then they can safely taper it down and discontinue the medication. But it's not something that happens overnight. Okay, so that's what you will have to see. Now, for home management, because a patient that has seizure activities is a long-term problem, so that child have to live with the problem. Every parent, every caregiver that has a child with any form of chronic illness, regardless of what it is, including seizure, that child or that the family members need to be trained, need to know CPR. Any parent, any caregiver that have a child with prematurity that was born premature should learn cardiopulmonary resuscitation. Part of their home medication also will be the Diastat, which is the rectal suppository form of Valium. They keep it at home because you know that sometimes when they are having that seizure, you don't want to put anything in their mouth, so you don't want to give them oral medication at that time. So you put it through the rectum, give them the Valium through the rectum. And the neurologist will write specific orders of how often they want the Diastat to be given. Most of them will write the orders as this. They will write Diastat, so milligram. Repeat after 2 minutes, or 3 minutes, or 5 minutes, times 1 or 2, and then take the child to the ER if no response. So they'll give you that specific orders to do. And preferably teach the parents to call 911 to transport them to the ER. Discourage them from driving the child to the ER. Putting the child in the car seat or putting the child in the back seat and driving the child to the ER. Discourage them from doing that. Rather, encourage them to call 911 and let 911 take them to the ER. They should also learn activities as tolerated, but they need to be supervised for activities that could put them at risk, something like swimming, that put them at danger in case they suffer a seizure activities while they are doing that activity. So they need to be supervised. Not that they cannot participate in anything, but they need closer observation. So for a school-age child, the school nurse needs to know that this child has seizure disorder, and they need to have like the medication, part of it with the original prescription sent to the school if that child needs to get those medications during school hours. So it has to be in the original container sent to the school nurse. Child needs to wear a helmet. Most of them, they have like a blue helmet, soft helmet that they give the child, especially the younger age ones. They wear that at all times so that if they trip and fall, they're still protecting their head. Remember, we break the head, then we run a bigger risk of not recovering or maintaining a normal life with the seizure activity. As with any other chronic problem, you need to wear medical alert bracelets. Okay, and that's what we're doing for that particular home management of the problem. Any questions? So in other words, once the child has the seizure, the neurologist will be on board in the case, and they will have to do their EEG, one-time EEG or video EEG, because they would like to characterize the form of the seizure that the person is having, and will be able to look at the pictures they are taking and their brainwave that they are getting from that video EEG to say, okay, this behavior is equal to these seizure activities in the brain. And they will have to describe it to the caregivers. That way they know exactly what physical signs they have to look out for on that particular individual to equate it to a seizure activity, and so that they can plan appropriately to help the person. Again, prevention of complications, further complications is what we would like to put in place here. We would also like to give the medications and maintain therapeutic levels of those medications that we are giving. having a seizure activity is not a life sentence for the child can still live the normal life, however, needs some supervision with certain activities so that if anything happens, then the person will be able to, tend to that child from. Okay. Any questions? So the next topic will be the neural tooth defects, which is something that you did cover in OB. So I will just run through it, and you know that part of the guideline with the pre-conception care recommended by everyone, including Machadine, is the use of folic acid to prevent neural defects. Ideally, all childbearing women should be taking folic acid. Young women, teenagers, because you need to prepare your body for that big event that will take place later on. Okay, so they need to. So with these neural tooth defects, yes, if you are not taking it or you are not eating food rich in folic acid, you better start now. It's over the counter. You can take it and you can get prepared. In fact, we are seeing patients. The other day was a 23-year-old couple with a child with multiple congenital problems, including, neural problems. So you can imagine that this is not, before we said it's, elderly primate, that will have deformities, deformed fetuses. No, these days it's happening due to our environment and everything put together. So you can as well do yourself a favor by preparing yourself, and if you plan to, prepare yourself and be ready and reduce your chances of any problem. Well, with this problem, we know that during prenatal period, with the alpha fetoprotein, we'll be able to identify some of those problems, during gestation. So they do the blood work. Several of them will have the spinal bifida occulted, and that's the one that you will, when you do your newborn assessment, you run your finger across the spine, or you notice that dimple or the tuft of hair will be that particular one, and that's just a very minor one. And we would like to notice that one as that dimple, or the meningocele, where there is slight protrusion of the meninges, but this does not contain the nerve tissue. However, the most severe one that we will focus more on here would be the myelomeningocele, which is when there is that opening, there is that lack of fusion. There is a protrusion of that whole sac containing the meninges, containing the spinal cord and the nerve roots, or the nerve roots. This is the one that we are looking into here now, and these are the ones that present most of the problem, long-term problem in pediatrics. The meningocele here, depending on how it's handled, can also pose a problem. Okay. So, what do we do with that defect? with their spinal bifida occulta, usually nothing is done, we just make a notation that is that data. With the meningeal cell and the myelomeningeal cell, that is that protrusion of that sac, which we will have to do everything humanly possible to maintain the integrity of that sac. We do not want to jeopardize its rupture. So what do? We need to get a combined dressing, which you know is bigger than a regular 4x4. We moisten it in saline and use it to cover the sac. This is also one of those times we would like to put this child in a prone position. Remember, we do not like the prone position in a child. We'll teach against it. Okay, but this is one of the other times that we may want to put the child in a prone position because we don't want any pressure on that sac. So we protect the sac, we put the child on the prone. And we would like to send this child out to where they can do the repair. Assuming we are in a smaller center where we do not have the neurosurgeons, pediatric neurosurgeons that can attempt to do the repair. So we wish for that repair to be done within 12 to 72 hours of life. And then post-repair, we will have to put multidisciplinary approach to it, but we have to have everybody involved in taking care of this big person. And this is not limited to the list I have here, because all have to come in place so that we have a better outcome for this child. The neurosurgery people will do the surgery, and then the neurologist will continue to follow up the child, and the neurosurgeons will still do what is happening, looking at. The pediatricians will be there to look at the wellness and other things that this child still have to do their wellness. The neurologist will attend to their renal function because they do have issues with maintaining their renal function. Some of them will have to, in fact, all of them, especially with the ones that have meningomyelocell, you need to kind of do intermittent catheterization in order to eliminate, empty their blood. So they need to have the urologist in place. The orthopedic surgeons will have to take care of the muscles and the mobility and all that with PT and the occupational therapy. Social services will coordinate everything, including getting all the supplies that this family will need and all the things that is going on, and then we'll do the rehabilitation that will put everything all together. So, and this child have to be followed by all these people. So that's like we need the coordination of care, and that's what needs to be done here. So, again, this is my recapping what I just said with the meningeal cell. Because problem with the latex allergy is now very, very minimal right now, because most of the catheters that they will use to catheterize this children, they are all now latex free. And also, these children also, they go to the OR so frequently that they run that risk of constant exposure for them to have that, but that risk is now kind of very minimal. They also have a very high risk of developing any increase in intracranial pressure and all the complications that surround that increase by virtue of that exposure of the spinal cord and all the nerve tissue. Okay. Another one complication that can happen will be hydrocephalus. There will be a blockage in the flow of the cerebrospinal fluid. Could be a complication from the neural tube defect, myelomeningocele. And when that happens, you may not notice it at first. Sometimes you may also, there will be a problem with circulation of the cerebrospinal fluid when there is either there is a blockage from infection or there is oversecretion of the cerebrospinal fluid itself. So it's not being reabsorbed as fast as it's being secreted. So there is excess. And once there is excess, that is, it's not, it's not circulating as much as it could, then there becomes an accumulation of it. Once it's accumulated, the ventricles will now become, this is the normal ventricle, and now with this distension of the ventricles, the cerebrospinal fluid, now you start seeing bulging, and you start seeing pressure on the normal tissues of the brain. See, like you have seen now here, this one is so much pressed on by this is pressed on by this, as opposed to here it's all free, and the brain tissues are just okay, but here the pressure here, it's pressing on the brain and causing all the problems. Okay? So, two types that you will notice will be the communicating one or non-obstructive one when there is impairment in absorption of the cerebrospinal fluid. Okay. And with that, there is just malfunction of the arachnoid villi that is not absorbing the cerebrospinal fluid. The other one, the obstructive one, will be when there is an obstruction to that part of flow, so the cerebrospinal fluid is not flowing freely, and that results in the accumulation of it, and that could be from trauma or any infection or even a tumor in the brain that can cause that blockage. So what do we do? Well, we have to monitor these patients very carefully, and part of the things that we need to monitor will be the neck circumference. We have to note the discrepancy between the size of the head and what it is at baseline. Usually the fontanelle is very much enlarged. Usually you will notice that the fontanelle is protruding, and then it looks like the eye is getting covered under the fontanelle. The fontanelle that will be referred to as sunset eye. So this is so much protruding, and then the eye is just begin trying to dock underneath the frontal lobe. Okay. Other things they can do to monitor that will be to look at the ultrasound, and they will be able to monitor the size of the ventricle, and that will tell them whether the ventricle is really increasing in size due to the accumulation or not. Okay. So once a child is diagnosed to have mouth flow or there is accumulation of cerebrospinal fluid, everything has to be done to reestablish that flow. Because if you don't do it, then now it will start accumulating, and it will start putting a lot of pressure on the brain tissue. so they'll have to do insert a shunt. They'll have to insert a shunt ventricular peritoneal shunt, they insert it in the ventricles and then thread it to go to the to the peritoneum, and it stays there. It has a one-way valve that it does not allow a reflux back into the ventricle. So once it leaves the ventricle, it just go back, just continue its way and not to reflux back. Okay, but once you have that, and this is something that this is a picture of what you will see. And once you have that in place, you need to monitor for signs of shunt failure. Because if it is flowing well, it will mimic like the normal flow that you have. But if it's not, there is a problem, then it will start to accumulate one more time. And something that you will notice if it starts accumulating, because you will start seeing increase in the intracranial pressure and all the consequences, all the signs and symptoms you will notice with increase in intracranial pressure. And one of those early things will be vomiting. That infection also can cause an inflammation, and that will block the flow. So the person may have a fever, may become so irritable. In children, as you know, we know that one thing that signals that the child is not feeling well will be their irritability and their inability to eat as their inability to eat as they would normally do. So that you see that as poor feeding. You see that as not responding to the way they used to respond, or the activity level will be decreased. Okay, or they can have seizure activity that is evident. Sometimes, most of the time, with these things that have a shunt, if you thread your finger across, you will be able to feel the shunt. Okay, and sometimes, if it is inflamed, when you try to, trace the shunt side, you touch it, the child will scream. Okay, so whatever you start noticing that, some of you that were able to see it on the unit, you see that that's really what happens. Once you identify there is a shunt malfunction, that child needs to go to the emergency room. Okay, they need to go because they need to relieve that malfunction as soon as possible. Otherwise, the condition of the child will deteriorate as fast as possible. Any question? Any questions with your shunt malfunction? So in other words, you need to monitor the head circumference, monitor the vital signs of the child, teach the parents what to look for, identify those early signs of malfunction, irritability, poor feeding, vomiting, and the whole, unduly sleepiness, increase in their seizure activities. Most of them also that have abnormality of the ventricles or the brain would have other abnormalities, other congenital abnormalities, and some of them would have may have apneic events. You see unnecessarily increase in apnea episodes that they're having. Okay, but you would like to notice the early signs of increase in intracranial pressure, which is what we did in the first few slides that we got. Any question? Okay. So, I'll move on to Down syndrome, which is trisomy 21. And we put this as the most common chromosomal abnormality in children. what happens basically is that there is an error in the cell division of the chromosomes, and that results in having extra copy of the chromosome 21. So instead of having, two, they have extra copy of it, and they have 3. And then on the whole chromosome, now I think you need 46, but in this instance you have 47. That's basically what happens here. And because of that, it could be due to extra, or it could be a translocation. Translocation would be when the chromosome 21 leaves where it should be and attaches itself to another chromosome. So it moves to another position on that Mendelian chain. So that makes it to move. That's the translocation. The causes, actual cause is unknown, but we have multiple causes that is linked to it. One of those will include increase in maternal age, and it's her research age 30 years and above, or 40 will increase the likelihood of 30 years will increase the likelihood of it 1 in 950, and 40 years and above will be 1 in 110. So in other words, the higher the maternal age, the more at risk that the fetus have to have Down syndrome. However, we are seeing younger age people that have children with Down syndrome. So on the other hand, cerebral palsy on the other hand will be characterized as impairment of movement and posture. So in other words, there is an abnormal development in the motor area of the brain, and with that it causes an abnormality or disruption in the brain's ability to control movement and posture. So in this one, the brain develops normally, but however there is that, in other words, the brain develops, the abnormal development here is just centered in the motor area, motor and posture here. In cerebral palsy, it is either a translocation or an extra copy of the chromosome. But here you have normal copy of the chromosome, but the problem is on that motor and movement and posture area where you have that function. So that makes the brain not able to control the movement and posture as it would. Things that can lead to that, we'll have a long list of that which we covered all along as we were doing increase in intracranial pressure. Hypoxia, asphyxia can be part of that, and other postnatal complications. However, these patients have identifiable causes, and we know that they are not able to achieve head control at all. It is linked to majority of them will have a form of congenital heart problem. They have hypotonia. They are short-stature. they have flattened occiput, and their head is very small, or if you will call it micro, typically as opposed to hydro, which is enlarged. They have a floppy tone. Other things they have short neck. They have excess space between their big toe and the second toe. So when you look at their toe, you have that extra space. It's so wide on their toes. They have extra part of fold in their inner corner of their eyes. When you look at their ears is low set compared to where you would find the ears to be. These kids are not able to sit without support at age 8 months. And they're not able to smile by age 3 months. And they have this white spot in their iris. Brush-filled spots in their iris of their eye. It's just like a white spot there. And they have feeding difficulties because they have this persistent tongue thrusting. They gag and they choke easily with their food. So, having identified all these problems that they have as a result of their motor and posture dysfunction, that will prompt us to put something in place to support them. We will use splints and braces. And we would like to promote self-care. Of course, these are patients that will have to sleep and to support them very well as they live optimal life, because this is a lifelong problem. So we administer their medications, and then sometimes they have to do surgery to relieve the contractures and the muscle contractures. We need to address the feeding problem because we need them to achieve optimal growth. And we need to provide stimulation, and we need to provide a safe environment for them. So, to sum it, for your management, you would like to promote growth and development, promote mobility, maintain optimal nutrition, and provide support and educate the child and the family. And you would like to prevent all the complications that will happen, including mental impairment, seizures, and or hydrocephalus or any other problem that will resolve optimally. Any questions? With cerebral palsy? Or with trisomy 21? Because all these are long-term problems that you need to support the child and the family to care for the patient. Well, another thing that we are seeing as a result of could be from cerebral palsy, could be from other insult, other complications, will be cognitive impairment. You will know that we do not like to use mental retardation per se. We don't want to use that at all. Neither do we want to refer to a child as a disabled child. Rather, we would like to refer to that child as a child with special needs. Okay. So, when do we notice that there is a cognitive impairment on a child? Well, we notice that once there is no response to contact, voice, or movement, it could be from the child is not hearing, or there is a problem with seeing. It could be a problem, we don't know, or it could be there is a disconnect between what the child is hearing and what the way the child is processing it in their brain. Child can be irritable, child can be very poor or slow feeding. They don't maintain any eye contact at all during feeding, and they have diminished spontaneous activity. So with that mental retardation or intellectual dysfunction, we can equate it with the IQ, intelligence quotient, of anything less than 75, according to the American Association of Intelligence and Development Disability. They will see that as intellectual disability as anyone that have an IQ of below 75 by before the age of 18. Anything that occurs before the age of 18, and you have all these at least two dysfunction in any of these areas, they would like to identify that person as having intellectual disability. And they will further describe that as mild, moderate, severe, and very profound. And for the mild one, they're looking at any IQ of between 50 and 70. Very profound will be less than 20. And that will be that person is really, really, really disabled. But the overall goal of this thing is to identify that person that has intellectual disability, and then you would like to provide appropriate education for that person that will allow them to achieve some level of self-care or self-functioning. And that can be achieved, they'll be able to care for themselves at home or in school, and majority of them will need minimum support. Now, if you think about it, you must have seen some of them in the grocery stores that they will come with their group leaders, and they are the ones that help to clean the shelves of the in the grocery store or retag their things. So, but they are all under supervision to do that. Most of them will live in a group home. Some, just a handful of them still live in their individual home. But majority of them live in a group home, and you do a structured teaching for them to be able to kind of still live their individual life. Unfortunately, people still take advantage of them, that they abuse them and take advantage of them, and including, taking their money and taking everything that really belongs to them. And that is not the way it should be. So, the whole thing would be our strategies, like to prevent this from happening in the first place. We want to prevent prevention, as we know, prevention. But once it happens, we autism is something that, we all have had some form of, news about it. It is a complex brain dysfunction, okay, that affects intellectual and behavior of the person. We have several types. We have autistic disorder, we have the Asperger syndrome, we have the progressive developmental disorder, not otherwise specified. Okay, unfortunately, autism has no cure, right? But we need to take care of them to be able to live a normal life as we're doing with those with intellectual disabilities, to support them, with prepare them to have them to live a normal life. But for this particular people, ours will focus on structured routine and behavior modification. Those are just the two things we need in autistic children. Give them a structured routine. These are not people that we give two-step instructions or three-step instructions and expect them to follow through them. Structure their routine. Even when they're in the hospital, everything is so structured the way they know it, and that's the way you have to keep it, and then you modify their behavior. You do these two things, you'll be able to manage them effectively, but it's still a big challenge to do that. So some of the possible causes again will be gene or abnormalities in the brain, or viruses or chemical toxins from our environment. Some of the warning signs will include no babbling by 12 months, no pointing or using gestures, or no single words by 16 months, or no language or social skills at all in any age. Other characteristics of these patients will be they are not able to relate to others at all. They are not able to communicate. They seem not to be interested in physical activities, or they're kind of not really, there is no obvious interest in any activity whatsoever. It's just self what they like to do. Sometimes they would appear as if they are even ignoring their own parents or their caregivers, and this is a point of pressure for the family. When they look at the child and they're trying to get the child closer, the child is kind of acting as if they don't even want to, they don't know who they are. So that behavior alone puts a lot of stress, a lot of discomfort on the family. So we need to support that family, because they are the ones taking care of this child, and we need to teach them how to modify that behavior of that child, because this is what we really do. Sometimes you will notice that this child, all they are doing is just opening and closing their hands, and just totally ignoring every other thing around them. So we need to support the family, and how do we do that? We need a professional guidance, and we need to modify their behavior. Okay? Because that's the way we have to help structure the environment. And some of the behavioral management things that we will put in place will include, we need to set limits for them. We have to provide that consistency, maintain that routine, be direct, kids. Do not pay attention to all the outbursts of misbehaviors that they are putting in place or they are displaying, but rather just be firm and try to control the child, use praise. And you only use restraint when it is absolutely necessary. But the child is in danger that you cannot do otherwise but to restrain the child. Other than that, just leave the child alone. But that behavior is something that really affects the family a lot. Another thing that is very similar to that, which some would lump both of them as one, but they are not, is the attention deficit hyperactive disorder, which is that inattention, impulsiveness, hyperactivity, and distractibility. Person is easily distracted. So the person does not pay attention, acts very impulsive, is very hyperactive, and is easily distracted. Those are the four prompts to attention deficit hyperactive disorder.
Go fuck yourself.
And this typically starts before the age of 7 years. Although some adults still have this attention deficit hyperactive disorder, you see it in adults as well. Okay, so once that person is identified as to have that, usually they will have very poor impairment in social and academic or professional functioning because they are easily irritated, they are very hyperactive, they cannot really focus or cannot even complete a task. They'll start this. Before you know they started it, they'll abandon it and they'll go to another thing and then charge their own path. Okay? So what do we do to help these individuals? We use medication in some children, and some of those medications that they use, these are all stimulants, which some parents do not like to use stimulants, and I don't blame them because all these have their side effects, especially the side effect of insomnia. Okay? You are trying to control somebody who is hyperactive, and you give him medication to slow them down, and that will make them not to sleep, and that will make them more miserable. So there is this, conflict between, using it, should I or should I not use it? So that, but studies have shown that when they use a combination of the medication and behavioral therapy, they seem to have optimal outcome. They seem to control that outburst of behavior and impulsiveness and all that better than when they use just medication that will have all these side effects. However, there is alternative non-stimulant that can be used, and that is the have like it's a non-epinephrine reuptake medication that will just inhibitor that will control the impulsiveness but does not contribute to the insomnia that parents are afraid of. And that medication is the atomoxetine, ATOMOXETINE, and that would be an alternative to all these stimulants. So it will control the impulsiveness, but will not contribute to the will not contribute to the insomnia and all the side effects that the parents are afraid of. Some have used that plus the behavior therapy and they seem to do well on that. Another thing is also to tell the classroom teacher, because the classroom teacher is frustrated, we are frustrated at home, so it is a collaborative thing that we need to do to get this child under control. And once that is done, usually they're okay, but you cannot control their outburst, so you still have to just follow them and modify what they are doing until you get such a. So those of them that are doing both do get a better outcome on that, but it is a problem for the family to have a child with them. Okay. Part of your thing with the parents, thing you did the child abuse, and this is just an overview of what abuse is, and it's not. So what we know is that abuse can occur in any place, any socioeconomic status, anybody is capable of abusing a child. It's not something that will be for high class or low class or middle class or red or white or blue. It's across the board and has been associated with parental low self-esteem and less adequate maternal functioning. Most often there is that incompatibility between the child and parents, or with all these environmental and social things going on, with lack of job and all that, misplaced aggression, you take it on the child. Poor child has no clue what's going on, but you displace yours on the child. Chronic stress, diverse, or even child can lead to child abuse. Okay, we have the abuse, physical abuse, we have emotional, or we have emotional neglect, or actual physical abuse, which we notice. In any type of abuse, whatever it is, what we need is to identify that child and take that child away from harm's way. A form of abuse that you need to be aware of is the Munchausen syndrome by proxy, and this is where the parents will come and fabricate illness, or the child will become a frequent flyer to the ER or to the physician's office with one form of symptom or the other. When you evaluate the child, you don't see any evidence of that. But mom will give you this classic history of what is going on with the child, and then the child will be put through all these invasive procedures, blood work and all that, and the child is just, when in fact there is nothing really going on the child, but the mom is just doing that to gratify herself or and put the child in endless misery. So that we need to kind of, when we see that coming up, we need to identify it and treat the child appropriately. So and these are some of those one of the symptoms that I just alluded to right now. Sexual abuse, of course, by definition, is what it is. It could be rape, it could be unnecessarily molestation of a child, or prostitution or incest. Okay, So now, child labor, child abuse, yes, we're using that, or you use children to gain money, and that's not right, or you're unnecessarily touching a child, of course, that's something we teach a child. However, regardless of what form or what cause it is, we need to identify that child, and we need to report it until proven otherwise. But bear in mind, there are causes of, um, you know, there could be some other things that could cause like physical, signs of physical abuse. Will be that is a disease process which we need
Just
to
make
rule
it.
out before we conclude that this is a child abuse case. In any case, we have to kind of treat it as serious
Right here.
and report it and take care of it as part of the problem that is happening. So you follow the guidelines of the hospital and report it on, to proven otherwise. Social worker has to be in place, and you need to interview the child with the parents and then away from the parents. Okay? If the child cannot verbalize anything and the child is capable of, give them a paper and pencil, they can draw for you. If the child cannot draw or cannot do anything, they can give them a play situation. Before you know it, they are demonstrating with their play doh exactly what happened to them, and you'll be able to put two and two together and ask questions towards that. But you have to be very, very alert to what the parents is telling you, the history they are telling you, and you're looking at the history they are telling you, and you're looking at the injury that is manifesting on this child. There is no link, and there is possibly no way that the mechanism of the injury they are describing to you can result in that kind of injury that the child is having. So that would give you a clue that something is really not going on right there. And it's just very important. Okay? Any questions? Okay, so prep you quiz will open tonight. I think it's from midnight tonight. I have 40 questions there, and the questions are centered on the seizure chapter and the endocrine system, because these are the two systems that we are looking to do in the next